it shows our pharmacy trend development. So there
got it.
is, in those red numbers you see on there, those are the experience period rebates and then our projected rebates.
Perfect. Thank you. All right, I think just one more moment. Okay, in terms of your administrative expenses, so you included a breakdown of your administrative expenses by type of expense at L&E's request. Could you speak a little bit about how you see each of those categories in terms of a breakdown of fixed versus variable expenses?
Yeah, do you mind, do you have the exhibit on hand? I just want to make sure I reference the right category names.
Yeah, hold on. I've looked at I was using L&E's memo, although certainly we could use a different exhibit if you prefer, but that's exhibit 21, page 15. And I believe it includes both, and that's the individual rate filing. And then it's exhibit 22. Page. Moment.
Well, I believe.
Well, we can start with page 20, exhibit 21, page 15, while I find it in the second, page 12 in exhibit 22.
Okay, so and bear with me for a minute. I'm trying to, yeah, some of these exhibits are so small I can't see anything either. I wouldn't feel comfortable speaking about these specifically fixed versus variable. It's something I would definitely be able to follow up and get you. I know that in our actuarial memo data set that we provide as part of the filing to L&E, we do provide fixed versus variable admin.
Okay,
and that would be at it wouldn't be at that breakdown that you see there, but it would be our total admin, how much of it is fixed versus how much of it's variable. And I was going to quote you that number, but it seems to be so small on my page I can't see it. I could go to the electronic version if you would like that.
Sure, that would be great. But certainly we could follow up if the hearing officer would like to keep us moving. We could just take that as a follow-up for after lunch or something. Whatever you prefer, Mike.
I think there's time, so if it's just going to take a little bit to find it, I think that.
Yeah, it shouldn't take
we can
me.
wait.
It shouldn't take me long. So it's just for page numbers. It's exhibit 1, page 45. Which in the printed version is exceptionally difficult to see.
Getting there as well in the electronic.
And maybe I was wrong. It's 46. My apologies.
Great.
And so it looks like for reading this sideways, but out of the somewhere in the neighborhood of, I would just say it's like 60-40 fixed. But those, without doing that math off the top of my head here.
I'm going to ask Chris, could you please clarify that statement? 60-40 fixed, I believe, is what you said.
Yeah,
What's the
60%.
fixed? What's the variable?
Yep, sorry, 60% non-variable, 40% variable is what we've stated from the most recently approved rate filing. And from the most recent experience period, which would be 2022, so I guess that's a different number. It's about 45% fixed, 55% variable, so it fluctuates a little bit year to year. With and we've had the expenses went up. We had some new expenses in 22, which we did discuss in the throughout the objections as well. But I'm not intimately familiar with what is fixed versus what is variable. Our financial planning and analysis team handles that. I'm happy to get you a breakdown by category if requested.
Okay, well, let me think about that before you do that work, and we can send out the request either later today or shortly thereafter. Thank you. So also in terms of, you were mentioning the 2022 shifts in admin, was that related to assuming the billing for customers who purchase through Vermont Health Connect?
Yeah, that was certainly a piece of it, a piece that drove it up, yes.
And if I remember correctly in your answers to Eleni, there were some offsets to that.
Yes.
And could you just briefly describe what those were?
Yes, I would like to reference that exhibit if you don't mind.
Sure. I don't know which one it was.
That's okay. Well,
look forward to. I was doing that from memory.
Yes, I definitely remember.
I'm usually a little better about having a million tabs, so my apologies for not being able to find it immediately.
Yeah, so I guess I'm looking at exhibit 15. I'm not sure if that is the one you are referencing. Which talks about the printing,
Yes.
postage, all that stuff.
Yeah.
I'm not sure there's any discussed offsets in here.
Yes, but it was my recollection, and I could be mistaken, that well, I'll hold the question and look, and I'll ask for follow-up if needed. So that's it from me, Hearing Officer Barber.
Board Member Holmes, do you have questions?
I do. Thank you. So actually, how you doing? First of all,
good. How are you?
Long morning for you.
That's okay.
Yeah, I know. We do this every year. We get ready for it. It's a marathon day. If you wouldn't mind turning to Exhibit 17 on page 8. And this is with reference to question 21.
Okay.
And this is about primary care and the comment that you made that MVP is a strong believer that primary care should be central to a patient's medical experience because having a consistent relationship with the PCP can avoid future higher costs. So I'm wondering, does MVP track the percentage of members that do not have an assigned PCP or the percentage who have not seen one in a given year?
Yes.
And then what do you do with the information there after? Do you try to assign them to a PCP? How do you, link them, connect them to a PCP?
Yeah, so there's some outreach that can happen, and this speaks more broadly, and happy to go into more detail when we get into the executive session about maybe the primary care model and how that piece ties together with this. But yes, we track utilizers, non-utilizers. Are they utilizing, and it's not just are they utilizers, but also are they utilizing consistently through one person, because that gets to the relationship piece of it. And it's more an education thing than anything else. Now, there are some members who are just pure non-utilizers, right? They use no services at all. And that's very difficult. But we do have things, we try to align our wellness programs and things of that nature to promote utilizing, getting your physical, getting these things that are free, right? It's free to the member. It's a preventative service. Get your colonoscopy, get those things, and create that relationship. But if the struggle, to be honest, is if a member sees 10 different doctors, then it's a struggle to figure out why. If a member sees no doctors, then it's also a struggle to figure out where exactly do they live, what doctors are near them, who's taking appointments, who's doing all of those things, right? So it can get very difficult to only have the insurer side of the data. But I think it continues to be a healthcare literacy endeavor, right? Of just educating members of, like, instead of reaching out and saying, Joe Smith, we want you to go see this doctor. It's more just trying to educate why PCP visits are important, why getting your annual checkup is important, why having that relationship with your provider is important, rather than specifically targeting a member and saying, we see you haven't gone to the doctor, please go to this doctor. Then you get into that, well, what is the health insurer trying to get out of me? It can become counterproductive, where they see it as you're using them for something. So it's a fine line to toe. But I think I see it as a continued education opportunity to try to just push people into getting that first line of care that a lot of people skip. And another example would be people who have had no PCP's visits for 5 years, but go to the ER twice a year, or go to urgent care every 6 months, right? Those are the people that maybe you can have a more targeted outreach, or you could discuss, you could maybe, I guess, target more specifically, like, hey, if you go here, or, we have a great solution through our app, our GIA telemedicine is covered in full now before the deductible for all members for all PCP visits, right? So it's not just a preventative visit. Any visit that you call MBP's telemedicine is covered in full. So, hey, why don't you use this before ER? Those sorts of things to make sure you need to go to the ER, make sure you need to go to urgent care. Maybe we can write you a script through our telemedicine, right? Something like that would promote all of those good things on a more, and we do promote that very heavily, because we think that's a very important thing, and especially on the affordability side, it's free. So those are the actions we take, but there's varying spectrums of the utilizers, non-utilizers relationships, so it's hard to have a single solution.
Well, just a quick follow-up, and have those efforts materialized in an increased usage of primary care?
I would say yes. Now what I'll say is primary care, in the sense that people are getting that first line of care. So our telemedicine maybe isn't going to be your PCP, right? Because telemedicine it's not calling up your doctor. It's calling up, MBP's book of doctors that work on the telemedicine platform. So it has increased, I'll call it primary care. I think there are other avenues that better address the relationship standpoint, and that is something that, again, I would get more into in the executive session if we wanted to talk about the relationship. But more primary care usage, I think that is what we strive to do. And then we have seen increased utilization in that tool.
Okay. Both filings include an upward adjustment to the premiums due to the increase in the COVID vaccine costs that you testified about. That now that, commercial payers in your filing and in your testimony will have to pay the full ingredient cost of COVID vaccines. And you adjust upward the claims cost from $40 to $130. Which it looks like from the filing increases PMPM by a little over $2 for both, $229 or $232. So I guess my question relates to Vermont has a vaccine purchasing program that reduces the cost of vaccines by, bulk purchasing at the state level. And those vaccines are actually paid for by an assessment that's made on all payers, including MVP, Blue Cross Blue Shield, self-insured employers. And I know that the program's 2024 increased assessment has already been factored into your premiums. So by including a separate increase for the ingredients cost of the COVID vaccine, are you assuming that the COVID vaccine will not be included in Vermont's vaccine purchasing program? And if so, what is the basis for that assumption?
The assumption is for adults. Yes, for children, it is assumed it's part of the program. We have seen in our claims data that I believe it's already, and I could be missing this, but I believe it's already part of the program for children. And MVP hasn't been incurring any cost for children, but adults we have. And I would say the basis for that is kind of a anti-answer, but we haven't heard anything to suggest and maybe there's new guidance on this or documents somewhere, I would be happy to take a look at it. But last we knew when we filed the rates, there wasn't anything suggesting that the adults would be covered. So we just continued to assume that it would be the children.
Okay, I think sounds like we should do some follow-up. Either MVP could do some follow-up or we should do some follow-up to verify that adults will not be covered in the Vermont vaccine purchasing program, because otherwise it seems to me there's a double counting potentially here of those costs.
I would agree. If it's going to be covered under the assessment and the proposed assessment we have in there, which I believe is the program's proposed assessment, right? Assuming that takes into account adults, then yes, you would not want to double dip for that. And I would agree that would be double counting. It's my understanding it's not, but if it is, we would reconsider for sure.
Okay. Can you just tell us a little bit more about how you arrived at the 34 cents PMPM increase in both markets for the new hearing aid benefit? My understanding, I think my recollection is it relates to your New York experience. Is that how you arrived at that? Can you just talk us to a little bit through that process?
Yeah, so hearing aid was not I'm sure everybody's aware, but hearing aid was not a covered benefit in Vermont prior to 2024. And so it has been in the New York individual and small group market, it has been a covered benefit. So what we did is we tracked that utilization over time, adjusted for any expected differences in maybe reimbursements of the hearing aids, which is something that I won't talk about here in this setting. We could do that in executive session if that's where we needed to go. But it's essentially looking at the utilization patterns of hearing aids in New York and assuming that is similar to Vermont. It's the only data we had. There's very limited data on hearing aids, so it was a difficult thing to get external data or use some other big enough block in New York that it would represent a reasonable estimation.
Okay, thank you. In May of 2023, so just a few short months ago, 3 of the leading manufacturers of insulin dropped their prices by over 70% for those individuals with private insurance, and it's effective for the most part in late 2023 and early 2024. Did you factor that significant price drop into your cost trends for 2024?
It is, I will have to follow up on a definitive yes or no. It would be baked into, it would come through the, let me say it succinctly. If the PBM knew that in our trends, it's in there. It's not something explicitly we did, but it would come through that trend component, but I can confirm whether or not it is in there.
That'd
But
be
yes,
wonderful.
I
And
will.
also by how
yeah.
much it impacted the rates would be also
Yeah.
helpful if you could confirm if
Okay.
in fact they did include it. If they didn't include it, I would like a follow-up with by how much that would reduce, the RX trend. What assumptions are embedded in the filings about the percentage growth in salaries for 2024 and the inflation rate on other administrative expenses? The general inflation rate.
Yeah, so I don't have the exact, like what our budget or what our expectation of salary increases are. I believe what we're assuming for an administrative increase is, or what we've budgeted across the board. So that's all inclusive of, or what we've expected for 24 was like a 3% increase over 23.
For salaries?
For administrative costs
Or for
in
administrative
total.
overall?
Yeah, so as far as how much of that is salaries versus we have, software expenses are going up or this is going down or that, I don't know the nuances of that, but I believe it was a 3% PMPM across the board, of which
Okay.
salaries do make up, I believe, over half of our, I'll call it personnel expenses make up over half of our administrative costs. So it is definitely a major component.
Great. Thank you. Are there any cost savings initiatives or opportunities that you became aware of after the filing was submitted? And that could be internal to MVP or external to MVP. Any cost savings initiatives or opportunities that just were not factored in this filing, but you're now aware of?
Not that I'm aware of.
Okay. And my last question, actually, this is a big 20,000-foot question, but there's been a recent study that was done by NBER and others that estimate that the adoption of today's already available artificial intelligence technology could actually reduce healthcare spending by 5 to 10% in the next couple of years. And they're suggesting that hospital and physicians groups could achieve, cost savings of 3 to 10% through, improved clinical operations, more efficient admin processes. And also insurance companies could actually realize 7 to 10% reduction in total costs from AI-generated efficiencies in claims management, member services, better waste and fraud detection, efficiencies in admin, better care management. The whole list goes on. How is MVP planning to utilize existing AI technology to reduce costs for subscribers?
Great question. I think the how is to be determined. I can tell you that personally, I do sit on a board here at MVP that is actively discussing these new technologies and how to best implement them and where to best implement them and how to do it safely, securely. I know there's a lot of, when you start talking AI and technology, there's a lot of components you have to factor in, but it is something that is definitely on the forefront of our IT department's roadmap in terms of things we need to do. And also in my role, I wear the hat as trend, and I oversee trend analytics as well. So it definitely impacts me day to day in thinking about those things to try to understand, like you said, okay, if we had AI overlaying our claims, what could we do for this? How could we have caught this? How could we get this better, right? So I think everything you said, I can't substantiate those numbers. It seems like the right thing and I don't disagree with anything you said. I think MVP is still working to navigate the technology and understand which technologies to implement and what to do. But it is definitely something that is on the high on the priority list, of course, as I'm sure it is for every company, and integrating that. As far as a roadmap, I'm unaware of one at the moment,
So
but the
you're
discussions are
unaware of,
ongoing.
are there any internal estimates of the cost savings that could be achieved through AI?
I think, well, short answer is no, because I think they're still trying to understand what to attack where with the AI. So I think it's the step before that.
Okay. I have several other questions about negotiations, so I will save them for executive session. Thank you.
Thank you.
Board Member Merman, do you have questions?
Sure, that'd be great. Hi, Chris. I
Hi, nice to
hear your
meet you.
voice often in the technical advisory work group, but I don't see your face, so it's nice to see you.
You as well.
Go ahead and call me Dave if that's easier. I'm new to this, and I have a wrist and a cast, so my page flipping is quite slow, and I've been struggling to keep up a little bit at the beginning here, but I'm doing pretty good. I have a few questions. I have a bunch of questions for you, but a bunch of them are just clarifications. I think largely because I'm trying to understand some of the where things are filed. When I look at Exhibit 1, page 5, page 6, actually, there's prior year total earned premium. This is on the individual filing. Then I look at this Exhibit 46 that you guys added, 2023 individual group market. Those numbers are quite different. So the prior year premium in page 5 is 110.5 million, roughly 110.6 million. And the 2023 individual market is 144.8 million. And there's similar differences on the small group. And can you just help me understand why those numbers are so different? I guess I would expect those numbers to be the same. What was allowed by the board for premium and what was earned by premium. The board allowed premium looks to be $34 million above the earned premium.
Yeah, so you bring up a good point, and I'm going to sit here and I'm going to tell you what's in the number, and then we can discuss whether that should be the number or not. So what you're looking at there with the 110, right, the 110,581,598 is the 2022 individual 110.6 from Exhibit 46. And I would assume small is the same thing. Now, it does say prior rate.
Okay. The 22. Sorry, I got my year. Okay, so 110.6. So that's the 2022. All right, so the 2023 requested rate's 124, and then that was 144.
Yeah, that's membership. So there's the requested rate of 124 for the individual market is as of our February membership, whereas the projection in January would have been before that. So there was a large membership decrease in January, which is PMPMs would make more sense there because there is just a volume difference. But I will go back to the prior rate piece, and we can take this back and try to understand with SURF really what they're looking for, because it says total earned premium and total incurred claims, which read to me like it wants to know the most recent full period, what you earned and what you incurred, which the prior rate, right, the 23 rates you wouldn't have earned premium and you wouldn't have incurred claims, you would have projected. So I don't appreciate exactly what that's supposed to represent. I don't know if anybody. Yeah, I'll follow up with the Green Mountain Care Board staff.
Okay, but I see that the
SURF.
22.
Yeah.
Okay, those numbers now align. The 2022 individual market 110.6 is the 110.6 from the prior rate earned. in the 130, those don't match up. The 2022 small group in Exhibit 2, page 6 is 132 million, and then the 2022 small group is in Exhibit 46, page 1 is 143 million. I'm just trying to make all the numbers make sense to me, as to understand how these all fit together, which
Yep. It's a valid point, and I don't have the answer off the top of my head. So it's difficult. There's membership is probably a piece of it, but there could also be a timing difference. I can follow up with that. I agree, though, it should be consistent. There might be a little bit of run out that's changing the numbers, but the premium run out should be, thousands of dollars, tens of thousands of dollars between those time periods. So it shouldn't impact it tens of millions. So I agree. I can't, at the moment, I don't know exactly the answer, but happy to find out.
Okay, cool. Thank you. Right. All right. I have a question for you on, just for example, on page 40, sorry, Exhibit 1, page 42, page 41. You're talking about your general administrative expenses. And I don't know if you actually need to, it's more of a conceptual question than a specific question here, so we don't need to actually have the page open necessarily, but you talk about your quality improvement, cost containment programs, your QI programs, that there's a PM charge for. And I was wondering if you could describe your QI programs that you have at MVP for these plans.
Yeah, so I think it's just our general quality, and I answered in a later exhibit. I don't remember the number, but we do a lot of things to promote quality. That I think why we call this out specifically is in the federal. So there's two types of loss ratios. There's your traditional loss ratio, which is just claims over premium, and then there's a federal loss ratio, which serves as the basis for if that is too low, you have to rebate policyholders. And in that, you get to remove taxes and fees from the premium, and you get to remove the quality expenses from the claims. So there's some, I think I said that right. There's some adjustments that can be made. So we like to call out the money we spend on quality and cost containment specifically, because in those filings, those can be separated. So when we talk about money spent on quality, we're talking about, education, things that we talked about with board member Holmes, like education on getting rid of low value care, creating good relationships, that sort of stuff. But then I think more traditional, like quality measures, which we may benchmark our physicians on. Are you spending, are you, what's the word I'm looking for? Doing or providing the quality of care that, is measurable. I know there are measurable. I'm not a quality expert, so I don't know all the measurables for quality, but it's around just essentially the money spent on those things. I don't think it's a specific like Vermont quality incentive program. It's just more MVP spends all this money on improving quality and cost containment, and that is reported separately on the federal loss ratio. So we break it out here.
Yeah, I guess my question is a little bit more general. I don't know if you know, but I'm a physician, so I think a lot about quality, like in my clinical practice. But what are the things that an insurer like MVP thinks about with how you would measure quality, and then how you would improve quality at the insurer level?
Yeah, that's a valid question, and I would have to defer to the quality team on that, and I'm happy to follow up after. They work tirelessly at these things, so I'm sure they would have a great answer for you. I wouldn't do it justice here, so I'll defer to them. But I know there are measurables that they have and things that they track to make sure, for example, are they getting the right amount of colonoscopy screening, right? Like just stuff like that they will be able to answer for you in a much more comprehensive manner than I could do.
Okay. And I guess with cost containment programs, is that referring somewhat to things like prior authorizations?
I think it's very broad. It may also be, I don't know exactly what the law, but I mean, when I think cost containment, that could also be like case management. That could be SIU, right? Fraud, waste, and abuse. It could be all those things. To me, fall under the umbrella of cost containment. But again, I'm not an expert, and I don't know. I'm not an expert at that like statutory rule, and I don't know what falls under the federal definition of cost
Okay.
containment. I'm sure there's
Okay, so-
something specific, but I'm not sure.
Okay, so I see this money is kind of is really this, as you said, that calling this out separately allows you to have certain programs that are necessary for your operations to be excluded from the rebate process through federal law.
Correct. That's fair. Yep.
Okay. So with regards to things, so to further my physician, I'm an emergency physician. So luckily for me, I don't have to deal a whole lot with prior authorizations. But when we work in like the primary care advisory group, or when I speak with physician colleagues, prior authorizations are a huge dissatisfier, focus of burnout. And so I'm trying to understand a little bit about, from the insurer side, why, what would be viewed as the positives, the benefits of a prior authorization program. Could you speak to what an insurer like yourself views as the benefits to doing prior authorizations?
Sure. So I think it depends on, what you're doing it for. We have undergone recently some reviews of some things, checking what makes sense to prior auth, what doesn't, right? So if we take service X and we review 10,000 of those a month and we approve 9,995, then the amount of physician MVP, employed physician time spent reviewing those compared to what you're going to save on those 5 is nothing, right? So that may be a waste, but there may be others that are more niche type. I don't want to say niche services, because there are several things that are not niche, but things that are vendor handled. I'll say that a small regional insurer like ourselves can't manage it. And I'm speaking in vague here. If you ask this again in the executive session, I'd be happy to give you more detail as to some of the programs. But I think what we see as the point of a prior authorization program is to ensure that, based on our medical policies and our doctors' opinions, the members are getting the right care at the right time, and that they're not jumping right to knee replacements when other things could be done. Now, ultimately, does that lead to a knee replacement, right? That's for us to analyze and to figure out what's worth it, what's not. But in general, the benefit is to curtail unnecessary spending based on a member and in their situation, and to see what savings can be achieved by directing them to a lower cost alternative first. That's what I would say in a broad sense.
So with things, say, like the knee replacement example that you gave, that I think you kind of implied that you track these prior authorization decisions and their outcomes. Is that the case?
Yes. Yep. We do internal reporting on our authorization programs and understanding what the outcomes are and whether or not the authorizations were actually saved costs. And now that when we talk about an ROI, there's a lot of things to factor in. There's your straight math ROI, like we saved costs, but then there's how much of a member dissatisfier is this? How much of a provider dissatisfier is this, right? Because we don't want to make the providers unnecessarily mad. We need the providers just as much as we need the members, right? So all of those things go into play to understand whether or not we should continue, or we should start, or we should stop doing something that we're doing. So yes, in short, long story short, yes, we do track these things, and it's holistic though. So I'll take a journey of a knee replacement where the member comes in and they want a knee replacement, and we say, well, what about PT or what about something else first, right? And then they go through PT, and then 6 months later they have the knee replacement. We would capture that as basically a situation where you added cost to the system, right? Because you had PT, then you had a knee replacement, then you had some more PT post knee replacement. And if you gave the knee replacement right up front, you would have actually paid less for that episode. But then there are several episodes where the member has PT and is good, right? So it goes both ways, and the summation of that drives our decision making.
Oh, I could actually, I'd love to engage in this conversation longer. I think there's so many questions I have for you on this topic. I guess I'll just give myself one more on this, which just relates to this, which is, do you track, say, when you say that member they didn't have a knee replacement and they're good, do you know if they didn't have the knee replacement because they felt better, or do you know if they didn't have the knee replacement because they felt dejected, in a sense, like they just, well, they're never, this didn't work and nothing else is going to work and I give up?
That I don't know the answer to. Like, I don't know the answer to that. That is part of survey metrics and outreach that we try to understand. I'm sure somebody within MVP has the call center and the marketing and engagement teams have that information. I don't have that at the tip of my fingers as to what drives the dissuasion from getting it ultimately. So it's a reasonable process, right? A reasonable hypothesis. I don't know though.
Okay. With two other things on prior auth, you implied that you for some of these sort of niche or other services, you kind of sounds like you outsource that prior authorization to a vendor.
We do, yes.
And do you outsource all the prior authorization components to vendors?
No.
Do you have an internal budget for, say, the Vermont plans of what it costs to do the prior authorizations for MVP?
I don't know if budget is the word, but yes,
Or
we
cost.
can. Yeah, we can track who's getting offed in, like who had authorizations and what is the physician time and in that. I mean, some of them are an in-house authorization is more of a direct cost because we employ physicians who do those things, right? But an external one where maybe you have whatever agreement you have with an external party, it may be harder to quantify the cost of a Vermont member's visit because it's part of an entire contract, right? It's not a one-off service like if it's done by an MVP doctor, it would be like, this costs X $100 to review, something like that.
So can you calculate a PMPM for Vermont members for the process of reviewing, approving, denying, managing prior authorizations?
I believe that's a number that we could get to. Yes, I haven't done it before, I'll say that, but I can certainly work with the leaders of the clinical team to understand their costs and all of those things, and I'm sure that they can provide those figures.
Do you know where in the budget, as we review it now, that would get that prior authorization PMPM would be included?
You mean like administratively?
Yeah, is this sort of under like general administration, or does that fall under the QI, which is a general administrative expense, or is there a different administrative expense line that I could sort of understand where that would fit?
No, I think it's part of, in my understanding, it's part of just general admin, salaries and benefits and all that stuff of the physicians on hand. And then where the maybe third-party arrangement fees live, I don't know.
Okay.
So I'm not sure if that's admin or that could be all other claim expense or something like that. I'm not sure.
It would be really helpful for me to understand sort of what the PMPM cost for prior auth is for MVP. I'm sure there's a PMPM benefit. Otherwise, or maybe understanding both sides of that would be very helpful.
Yep, that makes sense.
So can a few more questions? So this is on Exhibit 17, question 21, just to follow up on Jess's question regarding PCP assignments. One thing that that anecdotally, I think I just know this anecdotally and not from a data standpoint, that appears to be happening in Vermont right now is a lot of primary care providers appear to be leaving or retiring. And when you look at PCP assignments, do you ever track the PCP assignments due to retirement or departure of the PCP, or do you just sort of, or is that something that you guys can see from a data point, or can you just tell that they've changed a PCP?
I want to be careful how I answer the question. As far as assigning a PCP to a member, that would just show up in the data. I'm not sure, to be honest with you, how retirements are handled. I assume, yeah, I'd be speaking out of turn to
Okay.
understand what our provider data management team goes through to understand retirements and how they reallocate those things. I would be speculating.
One other thing I was interested in this section on page 13, you talk about a online cost transparency tool for members. Do you know if is that I've been interested in these online cost transparency tools, but I'm not a member. Do you know if that's something that a non-member can have access to review your online cost transparency tool? If you don't know, that's fine. I can figure it out later.
I don't know.
Okay.
I thought I remember saying it was before sign in, but everything we write here says our members.
Yep.
But I can certainly find out and send over a link if it is accessible.
Okay, thank you. Do you evaluate how people use that tool and if it changes their medical usage behaviors at all?
Not that I'm aware of. But I think as we get more and more data from the tool, which is relatively new, and continue to push the usage of the tool, which again is relatively, frankly, underutilized as I personally think it should be. I think it should be utilized more and more. I think there is a lot we can learn from that data to see. Now it's always a tough one to try to make the assumption of what the member would have done in the absence of what they did, right? But we could use historical patterns and see if they see how their care journey changed as a result of that calculator. I know I've used it anecdotally. I've used it on a personal level before, trying to figure out, which physician to go to, and saw the reimbursements and saw that there was a significant difference, and it did shape my decision making. So I do think that it can do that, and it hopefully guides them. I think there are other things at play though that should come in, like this is an MVP rated, right? Like you don't want to just direct somebody to the cheapest care. That may not be the best care always. So there's a balance there, but I think we need to help educate members more and continue. We are trying. It is health. I said it earlier. I'll say it again. Healthcare literacy, I think, is a continued issue in this country, and we all play a part in that. And I think we need to continue to help educate members on the best decisions to make. But offhand, I don't think we're using it today because there's not enough data to make reasonable conclusions. But I think your point is valid, and it's something that we should analyze as the data comes into a critical mass or some level that we feel confident in.
Yeah, that'd be great. A little further down on this, you talk about, and this may be for executive session, but you talk about the MVP's relationship with fixed prospective payments, and he says MVP and OneCare did transition from a shared savings only to a true risk arrangement. Can you comment further on what the true risk arrangement is in this open session with OneCare?
I would say I would prefer that to be in the executive session.
Okay.
I know the details of it. What I don't know is how public all of that is, because I'm not part of the negotiation, so I'm not sure exactly where it stands. So I'd prefer to keep it confidential.
Okay. And then one thing that you said in your testimony in relationship to Mr. Schulteis's questions, it says on A25 on page 11 of this same exhibit 17, MVP engages in competitive business, or maybe you could read that first first sentence for me, which would be exhibit 17, page 11, A25.
Okay. MVP engages in a competitive bidding process to obtain the best terms possible as a way of keeping administrative costs down when contracting out for a vendor or a service.
Sorry, I meant to say the second sentence.
Oh, okay. MVP negotiates rates that reflect appropriate reimbursement levels across all provider types in MVP's
Okay.
network.
Okay, so that's because I think you were asked if MVP negotiates with hospitals that the GMCB regulates, and this implies that you negotiate for appropriate reimbursement with all provider types in MVP network. Is that correct?
That's correct.
Okay, so that his question would then, my understanding is this answers that question in the affirmative. Would you agree with that?
Yes.
Okay. That is my last question for now. Thank you so much.
Thank you.
Chair Foster.
And Mr.
Chair
Fonte,
Foster. I'm sorry.
yeah, can you hear me? All right. I'm Owen Foster. It's nice to meet you. A couple
You as well.
questions. On the last page of Exhibit 26, the org chart, MVP Healthcare Inc., is that also a nonprofit?
I am not sure of that. I'm not sure of that. Yes. I guess I'm looking at the key and it says one is New York Not-for-Profit Corporation, and it looks like there's a 1 next to it. So I believe it is. We used to have a subsidiary that was a for-profit business, which we do not anymore. So I'm not a legal entity expert by any means. I'm just reading off the key here that seemed to suggest it is, but I can certainly follow up and get you that answer too. That is not my specialty.
Right. And then the RBC that we've been talking about, what level is that at? Is that for MVP Health Plan Inc.?
Yes.
And so what entities, operations impact that RBC? Just those underneath MVP Health Plan Inc.?
Yes, our financial statements, like our annual statement, this one we're looking at here is for MVP Health Plan, and that has its own separate financial statements as MVP, our other, article of business. And so yes, if you're interested in the businesses, like the markets that impact this, it would be it'd be New York Small Group and Individual, Medicaid, Medicare, and a portion of our New York Large Group business. A portion is on another legal entity, and a portion of our small group business in New York is also on another legal entity. But the vast majority of MVP's membership and revenue is under MVP Health Plan.
I'd sort of taken away through your testimony that the care board's decisions on MVP's rate request, the modifications downward, have had a negative impact on the RBC for MVP. Is that a fair characterization of your testimony?
I want to say yes. I would say the losses due to rate cuts have had a downward impact. I will say I do want to clarify that it is not the sole reason that it could have gone down, or it is not the sole driver of anything. It is a contributor.
Fair enough. That makes sense. What are the other contributors?
It would be performance of any of those businesses that I just listed. It would also be investment performance and things of that. It's things that would impact how much capital you should have. So that would be running your businesses, and then things that impact the capital you do have. So also running your businesses, but also in investments and other cash related activities that I'm not all that involved in.
Is there a way for us to, is there anything in the exhibits or any documents you know of that would help us understand the negative drivers on MVP's RBC? And what I'm trying to get at is, I want to know how much our rate decisions have impacted RBC vis-a-vis everything else that's dragging it down.
I don't believe it's in the binder here today, but that's something I could work with the the accounting and finance team to try to have them understand. I believe RBC is a public, fairly rigid formula, so it should be something that is could maybe even potentially be derived from the financial statement, but I'm not that sure, to be honest. But if that's something you're interested in, I'm sure we could help articulate that to you.
Yeah, I think that would be helpful. I forget if this part's public or not, so please answer accordingly. But my question is, what is MVP's current RBC? And then where do you think the RBC should be? Where would you like it?
So current is public. It's in one of the documents that, of course, I don't. I think it's in L&E's memorandum, which I don't
was like
remember.
389 or something then?
It's in the threes, yeah. Maybe Exhibit 21 has it here. 369.
360. And
what we would like it to be is a question I'll defer to the finance team. There's a lot of things that go into RBC. So RBC is a measure of solvency, tries to be. I'll say it's certainly not perfect. A really low RBC is a definite signal of solvency issues, but a RBC of 10,000 doesn't mean you're doing any better as a company than an RBC of 800. It could just mean you're sitting on more cash, right? You could invest that otherwise and buy down your cash for other things, and it could lower your RBC, but not really. So there's a healthy corridor type of thing. So in terms of what our company targets for an RBC, I would defer to the finance team and the CFO to answer that question for you.
And MVP has a Medicare Advantage plan. Does it just have one, or does it have multiple?
Can you define what you mean by plan, like benefit offering?
Yes. I think you're the administrator for the UVM
Yes.
Medicare Advantage plan. So
I believe there's three different types of UVM plans. And then if you're speaking to just Vermont, that's Vermont. In New York, we have numerous. But the UVM Health Advantage plan is MVP's Medicare offering in a broader sense, yes.
And when did that plan start operating?
It started operating in 2022, but MVP did have Medicare business in Vermont before.
Okay. Does it still have MA plan business in Vermont aside from UVM?
No, it all got rolled into that.
So as I understand MA plans, the early years can be more difficult financially, and then later years can be more profitable. Are there any losses dragging down the RBC at MVP from the Medicare Advantage plan?
That is certainly possible. As far as the quantification of it, I would say that would be included in your prior ask. I will say that the membership in the UVM plan is much, in our Medicare in Vermont, is significantly smaller than the commercial block or any other block we have. So the total impact could be mitigated.
Okay. I want to switch topics a little bit. Was it your conclusion that the rate submitted to the board for approval, or I should say the rates, is affordable?
I'll be careful with my wording. I believe what I answered directly was that what we have provided could lead to a conclusion that they are affordable. I think it depends on your definition of affordability and how you're measuring those factors. I think MVP does everything in its power to promote affordability and the best that we can within the limits we have.
Okay, so the wording is promotes affordable or could lead to a conclusion, but you're not concluding this rate is affordable. Is that correct?
I don't have a definition for which to gauge that against, but sitting here now, I wouldn't make the statement without having something to measure against.
And do you have anything to measure against?
I don't. I'll say MVP could create our own measure of affordability, but as Eric pointed out earlier, I am not uniquely qualified to make that assessment that everybody would stand behind from a third-party opinion type of standpoint.
Okay, I appreciate that. You said, and I think it was in your direct quote, we can make our own assessments of affordability, close quote. And I was trying to understand what you meant by that and how you would do that.
Yeah, so I think it's totally subjective, to be honest. I think in the individual market, I think the subsidies lead to a position where you could say that that's the federal government's definition of affordability, based on your percentage of federal poverty level. The piece that we struggle with affordability in the small group market is we have no insight into what the member pays. We know what the group gets charged, but we don't know how much that employer passes on to the employee. It's not in our data. We could get anecdotal here, there, but I mean, there's groups of 3, groups of 10, right? There's a ton of groups that are very small. So we don't know day to day what, if we're asking for 12.5% on small group, we're not sure if 0 of that gets passed through because the small group's doing well, or if 12.5 gets passed through, or more than that because the employer's doing poorly and they have to cut back from even where they were the prior year, right? So that's an unknown to us. We think that the individual market is kept affordable through the federal government and their definition of it, but small group is a gray area because we just lack data. So that leads us back. I will circle back to, we try to focus on everything we can do to make them as affordable as possible because we feel that's the main thing we can control. So how do we keep administrative costs efficient? How do we keep cost containment in line, right? What do we do to make sure that the Vermonters have the most affordable rate that we can provide to them?
Mm-hmm. Great, thank you for that. And I appreciate it on your direct walking us through your admin costs and how they compare relative to others in the industry. I thought that was really helpful, so thanks for that. Are there any levels at which you think I or my fellow board members should start having concerns about the affordability of this rate? So these rates are without a reduction around 15%. Would you say that's a level where we should start being concerned about affordability, or do you think that threshold should be higher or lower, or do you not have an opinion on that?
I don't feel it's my place to opine on that. What I will say is that it is a fact that, and I think Eric's provided a lot of data to support it, but it is a fact that healthcare costs continue to outpace any state's, income or anything like that. So that is a real problem, not in Vermont, but in the entire country and lots of the world, right? So that is a problem that we're all facing. And, as with annual medical trend of 7%, that's already double, what cost, inflation is, or what the, real wages go up, that sort of thing. So I don't know how to answer your question, to be honest with you, but I understand. I understand the concern and in the point. It's just I'm not sure what that line is.
Okay, thank you. You use the phrase, I think it might be from the rule or the reg, but the rates that MVPs put forth are not excessive. When you say not excessive, by reference to what? And what are you referencing when you say they're not excessive?
My definition of excessive is kind of backed into through not actuarially sound. Like it would be us saying, we want 20% medical trend when the hospitals are asking for 7, right? It would be these what you're asking for does not just cover your cost to get you back to your target margin, but it's way more than that. So you're passing those costs on to consumers out of, no necessity of your own. You just want to. So I don't think, it's more of an informal definition to me, but I don't think we're gouging customers. I think we're, as I said, with why we chose 1.5% CTR, we're trying to put our best foot forward and really ask for the rate that we feel we need, not something that leaves us in a position to harm Vermonters further on a cost basis or pass more costs on to them. Just because MVP wants more money, we just want to get where we feel like we need to be to operate sustainably.
I see. Right. So what I'm taking away, and I'm not trying to put words in your mouth, but what I'm taking away is the costs that roll up to these requests are all based on things that we don't have a whole lot of control of at MVP. So they're not excessive because we're not tacking on additional amounts, right? Like it's a terrible example, but I'm a golfer. And when you buy golf clubs, they tack on a heck of a lot more cost on them. And that's just for pure profit. What you're saying, it's really more controlled to the inputs that you're receiving. Is that what you are trying to get at?
Yeah, yes. And I think, you can look at I think a good thing to look at in our situation is our target loss ratio. I think our target loss ratio in Vermont is 91, 92%-ish. The federal standard for rebating is between 80 to 85%, depending on the size of the market. So we're, 7 to 12 points higher than that, which in our opinion means we're navigating this and we're charging premium for only the things we need to cover. We're not excessively, right? We could go all the way down to 80 and not have to pay money back per the federal regs, right? So that would be maybe excessive because if you're not spending that money, why do you need to take it in, right? But we are paying out 92 cents and projected in claims for every dollar we get. So we feel that that's appropriate.
You had quantification percentile basis for your admin costs. Do you have similar information as to where your target loss ratios are on a percentile basis vis-a-vis your peers?
I don't. I would defer to L&E if they know that information. I know on the I shouldn't say profit, on the CTR they did, and it was 23rd percentile for the CTR. But as far as the main two items that go into your loss ratio being not 100% are admin and CTR. So if we're very low percentiles in both of them, I would assume that would come together to give you a pretty low percentile on target loss ratio. I know 92 is pretty high.
Great, thank you. I don't want to get too weedy on the exhibits, but I think it was exhibit 46. I think it was that one. There's some discussion about adjusting the rates that MVP is requesting based on the hospital budgets, which I understand to be your testimony. You saw these new budgets and then the rates were adjusted accordingly. My question is, did MVP make any changes to its rate requests based on what non-hospitals requested?
I will say what I want to say it carefully. What we're altering is due to the total spend, I will say, that the Green Mountain Care Board oversees. So if there are physician offices owned by a facility that is regulated by the Green Mountain Care Board, that is included, but we are not adjusting for anything that MVP contracts with outside of the Green Mountain Care Board, whether it's in New York, the rental network, anything else like that. Those are more, we do those negotiations and those conversations internally, and that is on a timeline where we have a better knowledge of the number by the time we file than for the Green Mountain Care Board hospital budgets, which we know aren't going to come out till July, but will impact the rates. So I think it's a timing concern more than anything else.
Okay. I saw that phrase somewhere, rental. What was that referring to again? Just remind me. Yeah,
so MVP has its domestic network, which covers majority of New York and Vermont. And then for all members who buy all Vermonters who buy MVP products also get access to MVP's national network partner. So they can go anywhere and get in-network coverage within the country.
Yep, got it. Right. If the Care Board were to approve the full rate requests, how does MVP determine how to divide up the rate increases requests by, we'll call it the GMCB regulated entities and the non-GMCB regulated entities?
For you mean to, like, in negotiations?
Yeah, like what are some of the factors that are considered in determining how much of that rate increase goes to independent primary care practice here, hospital there, Dartmouth here? What drives those decisions?
Yeah, I would say preliminary budgeting. So the budgeting that we do to try to, before we file rates, determine where it's going to go. And that is a reflection of the trends in our rate filing, what we expect to happen at these facilities, and we stick to that. And I wouldn't say it's, I'll stop there and I can continue that in the executive session if we would like. I was going to give you a little more detail, but I think it's confidential.
So is that what you're referring to now? Is that the confidential portion of Exhibit 47?
It is related to that, yes.
Okay. So without getting into the confidential portion, what I'm trying to understand is, like, what are the factors that are considered in determining how much of the rate increase is provided to whom?
Yeah, I don't think it is looked at as how much of the rate increase goes where, as much as it is, here's what you have budgeted for this place. We need to stick to that, right? Or something like that versus, okay, the Green Mountain Care Board gave us 15%. Now let's go back to the drawing board. Who gets what? It's my understanding that's not the process.
Okay. You said it's based on what's budgeted for different types of providers. Is that right?
Budgeted / what we put in our rates.
Okay. And what's that based on?
The Green Mountain Care Board facilities are based on the submissions, or the prior submissions, if we make an assumption. The other facilities are based on either ongoing negotiations or the best estimate of future negotiations. And that is, I mean, it's a collaborative process between, it goes all the way up the chain to understand, what are our projections for next year.
Our goal and mission as a care board is, the three-legged stool, as they refer to it: affordability, quality, and access. Are any of those concepts included in how MVP determines where to allocate its rate increases?
Yes, I think quality, I would argue all of them are. I would argue all of them are in one way or another.
Okay, and I'm going to share what I think that means to me anyway, and you can share with me what you think it means or what it does actually mean to you. So, if I were making allocation decisions with a certain amount of money that I have, and I'm looking at quality, I would be inclined to give more money to a place with high quality. I'd be inclined to give more money to a place that has better access. I would be inclined to give more money to a place that is more affordable to keep them sustainable if they have sustainability challenges. I want to give the money where that's going to happen. Is that kind of consideration done at MVP when you're deciding where to allocate resources?
Yes. Yes, and that gets deeper into fixed perspective payment models and all those sorts of things where we could go into great detail and talk for quite some time about how all of those things play together and how really we're trying to, and I think is the new wave of healthcare, trying to replace the traditional fee for service with something that does promote affordability, quality, and access through not just a, pay when you go system.
Going to another topic, I saw that there was some movement in the volume of membership at MVP, and I saw some answers on this, but I didn't quite grasp them all. And what I'm trying to understand is whether or not you see any correlation, knowing it's very likely not one for one, but between the cost of the product and the volume of membership.
Certainly, I think it is likely the significant driver.
Okay. Do you have any sort of documents or resources that study that? And again, just to anecdotally, what I'm thinking is, if it's true that costs impact your membership, having a low membership is negative because it will increase your admin costs. It'll be a killer, right? Like the lower you get, the worse off the business is. And so I would want an analysis of like the price points that hurt my efforts to have sufficient scope. Does MVP have that kind of analysis?
I would say we engage in all our priceable markets, mainly commercial. We engage in strategic decisions around those types of things where we try to understand, it's part of it's making a decision, assuming what somebody else is going to do. Now in Vermont, it's a little bit easier because you got one competitor you're going against versus in New York, there's 20. So trying to understand what happened to them and what they may do and what that might allow you to do differently to get to the place you want to be is a little bit of a circular exercise, but an exercise that is fruitful nonetheless. And we do that and try to understand, right? Like if you raise your premiums too much, then you risk losing half your membership, and then the half the membership you're going to lose is going to be the healthy membership. You're going to be left with the sicker members, and then you're done, right? As you said, and so that all does come into play, but that all is balanced out by, is this market sustainable? How do we achieve the results we need to achieve at the same time, right? So it's not just, it's not like we're Apple, right? And we can say, what do we price the iPhone at? Because everybody's going to buy it anyway. So who cares, right? Like, what's our optimal situation? And we have 200 billion in the bank. It's a different story where we have to take that third variable into play and say, and where can we price it to also be sustainable at the same time?
Just got a new iPhone on Saturday, and your analogy there is correct. Unfortunately for my bank account. So coming at it from that perspective, do these rates that are requested give you any concern about decreasing membership? And if not, why not?
As they sit right now, not necessarily. I would be happy to talk you through strategy decisions and what we're thinking, but I have to assume our competitors are on the line here, and I don't want to go into that information that might give anything away.
Understood. Yeah, and what I'm getting at is, from a solvency perspective, it's not just the dollar amount of the rate that you get, it's also whether or not that membership stays robust
Correct.
enough to continue the operations. Related question, in terms of shifting membership into the different metal levels, do you see the cost of premiums and of the health insurance having an impact on what level of insurance people have?
Yes, I think generally there's been a buy down over, that's generally what you see year after year, is people buying down until, spending the same amount of money to get less for it, right, as premiums go up. Now it's an interesting dynamic. I'll go back to the point I made earlier. In the individual market, maybe not, because maybe they're insulated from it all with the subsidies, and as silver plans go up a larger amount, it might actually make a gold attractive, right? So that can skew what would be traditional price-based decisions, because that's not really what they're paying. And then in the small group market, it's also hard to know, because it's not consumer driven. The member necessarily doesn't always have the choice of, I want a platinum versus I want a bronze. The employer is going to give them options, and what or not, and just say, this is your plan. So what the employer decides is a different decision-making set. But to answer your question in a broader sense, yes, I think average benefit richness of the membership base has gone down over time due to increase in cost. All else equal.
I'm going to try and speed it up a little bit, just to be respectful of time. But the subsidies we touched on a little bit. When do those go away as of current plans?
It is my understanding that 26 they would no longer be effective. So through 2025.
Okay. So next year's rate review will be the last time we have them as part of our, yeah, okay.
Yeah, unless the federal government chooses to extend or do whatever. I know it was a kind of a last minute decision this past time to extend, so I'm not sure. I mean, it's anybody's guess what happens there.
And so if you go to Exhibit 20, page 4, really 4 or 5, 6 and 7. We see these are charts from L&E of the portion of income to buy the lowest cost plans in different metal levels. And you see they're generally in all these charts, they're higher in terms of the percentage of family income in 21, and then it drops down in 22. And this goes to your point about, you know, the federal programs, subsidies make them more affordable, right? And so in 26, if the subsidies are not renewed or continued, are you anticipating that these charts will go back up significantly to account for the absence of those subsidies?
All else equal, yes, I would be, and I'm sure L&E may have spoken to it or could speak to it as well, but I would be concerned about some sort of shock event where people drop coverage or do other things. So while these numbers the numbers will go up in 26 if there's no subsidies extended, I would be also concerned with the dynamic impact it had on the market of, right, like, okay, I went from having to pay 5% of my income and now it's 20 and I can't afford that, so I no longer have insurance, right? That's obviously not the outcome anybody wants, but in a consequence that could come of it as well. So the numbers will go up, but there's more to it than that as well.
Right. And that's sort of my concern, is that these rates are going up, and just to be totally candid, in my mind, part of it is, okay, well, we have subsidies, so it's not as bad as the actual absolute number on the rate. But then we might have 3 years of rate increases with that consideration in our head, and at least a potential that goes away, and there's a real whipsaw for the consumer on this. And I'm a little concerned about that. Does MVP have any thinking or plans around that potential contingency and what to do about it?
Not at the moment. I would say that I'm sure MVP would lobby to its extent to continue, and I know we did the first time, to continue the subsidies, because it doesn't matter, like, MVP doesn't care necessarily whether you're getting a subsidy or not from a revenue in standpoint, right? It just comes from the government. So we would rather more people be insured, and that helps the overall health of the population, and that helps bring costs down. The more people that are insured, that goes back to the genesis of the ACA with the individual mandate, is the bigger the pool, the less you can lower the overall morbidity of the pool, rather than having only the people who need it insured. So I think MVP is all for everybody getting the care they need. But in terms of what that would do to the member, I'll be honest, I'm not sure at this time how we could impact that, other than continuing to push, I'm sure, as all other health plans will be, to continue these subsidies.
Right. You might not have this, so I apologize, it's a little far afield, but do you have at MVP, any projections as to what that could do to the membership volume that you have if the subsidies go away entirely and the rates are significantly higher? I mean, as part of your lobbying effort, that might be relevant information to what that would do to the market.
Yeah, not at this time. I think it's probably a little bit early for that.
I think this is my last question. Dr. Merman spoke a little bit with you about the cost containment and quality initiatives, and you said there was a PMPM associated with that. My understanding, that cost containment and QI efforts is to lower costs, right?
Correct.
Is there a corresponding PMPM savings that correlates to those cost containment and QI efforts?
Yes. So this is very much related to the similar question on the prior authorizations, right? We can tell you what it costs to administer the program, or what it costs to do the authorizations, and we can have a calculated ROI on such programs, which then could back you into the savings. But ultimately, the savings are in a reduction to claims, right? So the savings are implicit in our experience. To and that's why I made the comment, we continually are evaluating the performance of these things, because if we determine we're spending money to have a cost containment initiative that's not containing cost, then you are spending money without reducing the claims at least as much, if not greater level. It doesn't make any sense, right? Then you're just wasting money. So yes, there is always a positive, or there should always be a equal or greater offset to that, but that happens through the claim expense. It's not a tangible, like separate line item. It's just medical claims are lower. We had less of this because we did this. We drive people to higher value care, which reduced this type of thing.
Great. Yeah, and that's what I'm getting at. Do you have that data that shows, are you evaluating your cost containment and QI efforts to know that you're breaking even or saving money in that reduction in claims?
Yes, it is a iterative process that I would say we continue to work through. So I wouldn't say it's 100% comprehensive at the moment, in terms of we could, won't be able to turn around for you by the end of the week a full list of everything and their ROIs, and here it is. But we're continuing to evaluate, and we have made changes recently to things that we didn't deem more valuable. So it's working through all of the programs to make sure, again, that MVP is spending the money we should spend. So it is something we are doing, but maybe not something that is 100% at hand, ready to go.
Great. I have no further questions for you, Mr. Pontiff, and thank you very much for your patience and time. And I'll turn it back to you, hearing officer.
Thank you. Are there any board questions before I turn it over to see if Ms. Beliveau has questions? Anything
Could I
additional?
follow up with just a few board questions?
Yeah.
Chair Foster brought up something on the RBC. So money that's set aside as RBC for a period of time, is that money invested in the market or invested somehow?
It is my understanding that RBC, your required capital is what it takes to do business, and then it's a measure of your actual capital. So I believe that that includes, yes, assets that would be invested.
And then, so I'm looking at Exhibit 21, page 18, these RBCs. This is in the L&E report. I'm sure Exhibit 22 has a similar, I didn't look to see if they're the same at this moment, but do you know how much of the decline in RBC from 20 to 21 was market related? I know that a lot of hospitals saw a lot of market declines with regards to their days cash on hand. Did MVP experience a decline related to market value of their invested RBC capital?
I would just
have to-
caution, this is something that should be discussed confidentially. I don't know. Maybe.
Yeah, I'm not sure if it's confidential. I just don't want to give the wrong answer. So I know that, the investment performance matters. I don't know how much of it is for that. So
I'm just, we've been implying that, the loss of the Vermont business for MVP could impact the RBC. You discussed different things that impact RBC, and I'm trying to understand what the impacts of those various things is, and if investment losses had a significant impact on RBC in this time period, or if this is more due to loss secondary to rising costs of healthcare related to premiums.
Yep, valid question. I don't have the answer offhand.
Is that an answer you think we could get as a board, even if it's confidential?
I would think so. I would have to defer to the accounting team. I mean, they calculate the RBC, the finance crew, but what goes into that RBC, we should be able to lay out the pieces of it. I mean, there's going to be a lot of moving parts, but we can help summarize what may be the biggest driver.
Total pivot of a different question line here. And I'm sorry, I'm just going to tell a super brief story, but when I was in medical school, I had this mentor, Harris Berman, who subsequently was dean of my medical school, but wasn't at the time, who in his retirement came to my medical school. And earlier in his career, he started what subsequently became the Tufts Health Plan. And I remember sitting in his office and him telling me about, the derivation of this nonprofit health insurance company to and one of the things he said was, he'd go on rounds in his hospital and he'd see all these, the cardiologist had stacks of EKGs on every single patient every day that he was billing for, and that they said we need to start a way to ensure that our patients aren't. This is kind of the opposite of the prior authorization discussion, right? We need to develop a way to ensure that our patients aren't receiving all of this unnecessary care that people are profiting off of, and deliver high quality care. And I guess I just, while you were talking with Chair Foster, I guess I just had this question of, when you think of MVP as an insurance company, as a part of the health system, what is MVP's real essence of its role within that health system?
It's a good question. I think our mission, our values are to provide high quality care, and not only that, but high quality personalized service to our members. So I think our role as a regional nonprofit is to provide a deeper level of care and a deeper level of service to a member that they may not be able to get elsewhere. And I think the bigger philosophical question of, is the insurance company there? I think my belief is that the old school, the insurance company is there just to pay my claims, is not the way to do it. I think we are trying to make MVP a part of their lives and help them understand that MVP is there for them, and not turn it into which I fully appreciate can happen sometimes between the physicians and the insurance company, where it's a physician versus MVP's physician says this, and then it becomes a battle of, who do I trust more? Who do I want to do things for me? But I think what we're trying to instill as a culture for our members is that we want to be a part of their life. We want to help them with their wellness outside of life, or outside of healthcare services specifically. So like just day-to-day mental health, those sorts of things. We have, wellness programs that do things like that. So trying to be not just hey, when you go to the doctor, let us know, we'll pay for it, but a more collaborative partner in their health, which is, I think, the role of a good regional health insurer versus, say, a national, where that level of service just can't be provided. So I think that's what we're trying to do, is trying to get away from just the fee for service, bill me, I'll pay it, and think of us as more of a partner in their care journey. I don't know if that answers your question.
Yeah, I think to a large degree it does. The characterization that Dr. Berman gave me, which sort of surprised me, I think, at the time, because I probably had a different view of an insurance company, was that the insurance company has the ability to be, compared to an uninsured person who is paying cash out of pocket for everything, to be kind of a leverage negotiator for more affordable prices through sort of a bulk negotiation. Is that something that you feel an insurance company, of the role of something like of a company like MVP is?
Yeah, I think so. I mean, I have personal stories where, people come to me all the time. And of course, being an actuary for a health insurance company isn't exactly, the thing I lead with when I meet people for the first time, because that generally is like, okay, well, we all hate insurance companies, so I must not like you if you're making the rates. But, I think the insurance company, MVP, we do provide a valuable service. And like you said, paying cash out of pocket. I mean, we have claims that come through our doors that have billed charges for $2 million. And because we've negotiated rates and we have, relationships, they pay for maybe $150,000, and that member may pay $2,000, right? So that member, one, MVP negotiated a lower amount, but two, the cost share piece of it, but like millions of dollars get billed on these things, right? And I think there is a huge service to the bulk negotiation versus the bill charges, and what value insurance can provide people. I always like to make the analogy that if you have, a 2-week, 3-week inpatient stay and that runs you $200,000-$300,000 and you're uninsured, are you filing for bankruptcy? Like, how does that disrupt your life, right? Does that end all financial freedom in your life for the next decade because you owe the hospital, owe the facility this money? And not that that's wrong on the facility. They provided you services that are being billed for that rate, but the insurance company does provide that coverage and that level of care that can save a lot of people from a lot of financial harm. But that's in essence, that's what the insurance business is for. But I think healthcare is a very unique one where the tail of cost is very, very high, and it protects people from truly catastrophic life outcomes that, I think the people who get that help truly understand it, and some don't until they get in that position. But that's what, in my opinion, some of the best benefits that you can provide as compared to like an uninsured per se.
Thank you for that. When you think about providing health insurance in Vermont, which is, we discuss quite frequently in our meetings about a sort of unique state that's different between the care board, how the hospitals are organized, our population, whatnot. What are are there unique challenges, or are there unique uniquely easier things to do when you're providing that affect your ability to provide low cost, high quality health insurance in Vermont?
It's a great question that I may by virtue of MVP not be that qualified to answer. Like, I think Vermont definitely utilizes services differently than New York, but I have an N of 2, right? Like if we were united here operating in all 50 states, it'd be a very different answer I would probably give you, because Vermont compared to New York is one thing, and politically, Vermont and New York can be similar in a lot of ways and have very similar, say, it's all community rated, so there's one rate for everybody regardless of age, whereas a lot of other states don't, right? So it's very difficult for me to say like unique challenges due to Vermont, because New York and Vermont have a lot of similar challenges and benefits of their healthcare landscape. But I'd be trying to find the differences. But yeah,
I'm sorry to interrupt, but I guess I was sort of thinking more specifically related to the Green Mountain Care. I mean, you do bring up the Green Mountain Care Board hospitals that you're going to find out the rates later on. We sort of seem to define the maximum rate if those provide unique challenges, and how that affects your ability to set competitive rates.
Yeah, I mean, it's definitely a unique situation where there is no regulatory body on the facilities like that in New York. So this nuance of the rate filing is definitely challenging. The timing of it is challenging, and I think everybody who's been through it a couple times understands that and realizes the challenges with the rates are due in May, but the budgets aren't due till July. But then you have to make the decision on the rates before the decision on the budgets, right? So it's a very difficult timeline for everybody to navigate, not just us, but the board. It's a huge task for you guys as well. And so it does present those challenges in understanding, in one way it's a little bit simpler because there are a lot less facilities in Vermont than there are in New York. So it's simpler in that regard, but it's also the timing of it is interesting, and the care board's role in it all is definitely different. I wouldn't say it is worse or better or anything, but it does provide a unique set of challenges that New York does not have. Simply put.
All right. Thanks. I don't have any further questions now. Thanks.
Okay. Why don't we take a 5-minute break? Some point we're going to have to let Chris go. The plan after we get back from break at 12:51 would be to give Laura Beliveau a chance to quickly ask some questions in case she has any, and then turn it over to Gary for any redirect that he may have. And then there was talk of an executive session. I think that would best come after Jackie Lee's testimony, because there are portions of the L&E reports that are confidential around the CSR silver loading issue, and best to tackle all that at once. So let's reconvene at 12:51 and do that. Okay.
The record.
Okay, I think we are, looks like everyone is back, so let's go back on record.
On the record here.
And Ms. Beliveau, do you have any questions for Mr. Pontiff?
Hi, good afternoon. Yes, I do. Hi, Mr. Pontiff.
Hi, how are you?
Hi. And I'm just going to preface this by saying that my laptop doesn't always believe I have Wi-Fi. I do have Wi-Fi, and so if I freeze, I have an iPad lined up to jump right back in. So everyone remain calm. If you could turn to Exhibit 45. And could you estimate what the rate changes are for the silver plans versus all the other metal tiers?
Yeah, I think on average, the silver plans are going up 0.4%, and then everything else is down about 0.1%, roughly.
And
You're talking about just for the CSR recommendation from LNE, correct?
yes.
Okay.
Would you be willing to follow up with something that documents that calculation?
Yes, I assumed post-hearing LNE would be reaching out to confirm our calculations. Yeah.
Excellent. Okay, and then turning to Exhibit 46. And I would just like to confirm my understanding that the column that's labeled overall cuts proposed by LNE.
Yep.
Those are cuts that were actuarially based, but that MVP didn't agree to. Is that right?
That's correct. Yes. Yes. Difference.
Okay.
I'll call it a difference in actuarial opinion.
Right, but they're based from LNE's perspective on actuarial recommendations.
Yes.
All right. Thank you. Those are my questions.
Okay, turn it back to you, Mr. Carnegie, for any redirect.
Thank you very much. I just wanted to follow up on 2 points, Mr. Pontiff, that the HCA asked you about, that Eric asked you about. Let's see. First, you don't have a legal degree, right?
That's true.
And you don't have a master's degree in affordability, correct?
Don't have any degree in affordability.
And you don't need to be an expert to provide information about that the board could then conclude from that information whether a rate's affordable or not, right? You don't need to be an expert to provide data, correct?
That's correct.
Ultimately, it's the board's decision on what is affordable and whether it's affordable under the statute, correct?
That's our understanding. Yes.
And then if you go to Exhibit 1, please, just go to the last page and tell me how many pages there are in Exhibit 1. That's our individual rate.
Under 165.
Okay, and then go to Exhibit 2, please, and tell me that's the small group rate filing. How many pages there are there?
162.
And would you agree with me that those rate filings and all the decisions that you and your team made in the rate filings ultimately were aimed at making the rates as affordable as possible?
Yes.
And would you agree with me that the other pre-filed testimony and then the exchanges you've had with various folks asking you questions today about rates, that's all evidence about affordability ultimately, isn't it? Whether the rates are affordable.
I believe so.
Thank you. And then the second point, are Vermont ratepayers subsidizing New York ratepayers in the 2024 rate filings?
No.
When you set rates in Vermont for the Vermont business, is that a standalone proposition, or are you setting rates considering what's happening over in New York State?
All markets, regardless of state, are priced on their own.
Do the rate, Exhibit 1, Exhibit 2, do those rate filings depend upon events taking place in New York?
In New York business, no.
And if you would go to Exhibit 46, please. 46.
We can't hear you, Mr. Schultz. Were you trying to eject?
No, I'm all set. Thank you.
Oh, sorry.
Can you hear me
Apologies,
okay?
hearing officer. Yes,
Can you hear
sir.
me right? Okay. So go to Exhibit 46, please. Let me know when you're there.
Okay.
And you see the second column, it says MVP proposed CTR. You see that?
I do.
And you see how the numbers are, there's 2% in 2019, and then it's 1.5% each year after that. Do you see that?
I do.
So is there a spike in the CTR request by MVP that somehow relates to the Hudson Health Plan issue in New York?
No.
Thank you very much. That's all I have.
Mr. Schulteis, do you have any questions about those points?
Just one point of clarification. Chris, so I thought I heard you say earlier that RBC is calculated at an enterprise level. MVP Healthcare works in Vermont and New York, so it is connected, I would think, correct?
Objection, that's beyond the scope of the question I asked. I didn't ask about RBC.
You asked if they were connected at all to New York, and I'm asking if that's true.
Yeah, I think it's a fair question. I get the point. If you could, sorry, restate the question, Eric, in a little bit.
Did you just say, Mr. Pontiff, that the rates are completely independent? What happens in Vermont or what happens in New York doesn't affect Vermont at all, correct?
I said the rates are set independently of one another.
So they're set. I'm sorry. How can that be true if RBC is calculated at the entity level?
RBC was not a leading factor in determining anything in this rate filing. The rate filing is derived based on the data of that block, and that block needs to be sustainable on its own. So we can talk about RBC in the bigger picture, but at the end of the day, the CTR for this filing is grounded in the long-term sustainability of the Vermont individual and small group products specifically, independent of its impact that it may have on CTR.
So you don't look at the overall solvency of the organization, Chris, when you set CTR?
We do. If it is more of a binary, if MVP was in trouble, if MVP had significant solvency concerns, then that could potentially impact it. It is not in these filings.
Quick, so to follow up on that, so you said it's concerning and not sustainable that the organization had long-term losses, right? So on one hand, you're saying it's a concern, and on the other hand, you're saying it's not a concern?
Yeah, so what we're saying is concerning is that the small group and individual rates have long-term sustained losses, not that MVP health plan has long-term sustained losses.
Okay, thank you, that's all.
Okay. Are we prepared to move on? I think at this point it makes sense to take a lunch break. Come back and hear from Jesse Lucier from Department of Financial Regulation, followed by, oh, sorry, I'm getting ahead of myself. Mr. Carney, do you have any additional witnesses? You had listed Julia Dorr as a potential witness.
No, not this time. We might have a rebuttal witness if we put Chris back on.
Okay. Then I propose we break for lunch. Come back, like I said, hear from Jesse Lucier from Department of Financial Regulation, followed by Jackie Lee, followed by an executive session. I think we have time for all that. So why don't we, any objections to half an hour lunch break so we convene at, say, 1:40?
Fine with me.
Okay, then let's reconvene at 1:40. And Mr. Lucier, are you on?
Yes. Can you hear me?
Yes. Does that sound okay to you?
Sounds good. 1:40.
Okay. Talk to everybody then. Thanks.
Thank you.
My apologies. It's like a 4-lane highway at my house today, so I apologize for being a minute late.
Not to worry. So it looks like we're all back. So let's go back on record.
On the record?
And the next witness is Jesse Lucier from the Vermont Department of Financial Regulation. Jesse, I'm going to swear you in at this point.
I'm sorry, could you repeat that?
I said I'm going to swear you in at this point. Could you please
Okay.
raise your right hand? Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God? Didn't catch that. You might be muted. It's still showing
How
you as
about-
muted. Nope.
How about now?
Now I can hear you.
I didn't do that. Somebody muted me, so I'm the 802-798 number. My phone is wavering between 1 and 2 bars right now, and I've dropped the teammate meeting several times already today. So if you can't hear me for any reason, I apologize. Just let me know. Let's start. My name is Jesse Lucier. I work for the Department of Financial Regulation. My official title is Administrative Insurance Examiner. As an insurance examiner, I am involved in all aspects of the examination and analysis of insurance companies. At a high level, examination is similar to a financial audit with more of a lens towards prospective information, and analysis is a routine quarterly review of a company's financial statements. As noted in the solvency letter, the New York department is MVP's primary regulator, and Vermont relies on New York to inform us of any solvency or concerns or issues they would have with MVP. To date, New York has not notified the department of any immediate solvency concerns. I'll just read a couple parts of the letter as I am normally asked to do. So I know Chris had read these, so it might be a little bit cumbersome, but page 1 of the solvency opinion, the summary of the opinion states, the proposed rate filed by MVPHP would not negatively impact its solvency, and the company otherwise meets Vermont's financial licensing requirements for a foreign insurer. And I'll skip to the final paragraph that states the impact of the filing on solvency. In its filing, MVPHP has requested that the board approve an overall average rate increase of 12.8% based on the entity-wide assessment above and contingent upon GMCB actuaries finding that the proposed rate is not inadequate. CFR's opinion is that the proposed rate will not have a negative impact on MVPHP's solvency. I know we've talked about the 12.8%, which was in the original filing. That's going to be updated or amended. From what I understand, the rate's going to be changed to somewhere between 13 and 16%, depending on how a few variables shake out. And the department's opinion would not change, assuming that Lewis and Ellis agree with the final updates. So I'm just going to end it there in the interest of time and pass it back to you, Mike.
Thank you. Mr. Carney, do you have questions for Mr. Lucier?
My partner, Mr. Long, will handle the questioning. Thank you.
Thank you.
Good afternoon, Mr. Lucier. Good to see you again this year.
Good afternoon. You too.
And at any point, if you can't hear me, just stop me, let me know, and we'll repeat the question. I know you have some cell reception up there. First of all, I think you took away a lot of my questions. That explanation was really helpful. Thank you. I'd like to clarify just a couple of things. I think we're all on Exhibit 18, but if you're not, could you please go there and let me know when you're there. Are you there? Jesse,
I
are you
am.
there? Okay,
Yeah,
thank you. And this is dated July 5th, correct?
correct.
And now, July 5th, that would have been before the L&E actuarial memorandum and before hospital budget requests were released. Is that correct?
I believe so.
And did you have an opportunity to review the L&E actuarial memorandum before issuing the solvency opinion?
I skimmed it. I can't say that I'm an expert on. I don't have any actuarial credentials, so I did review it, but I can't say that I fully could explain everything in there.
Okay. But this solvency opinion, the July 5th one, deals with the original rate request at 12.8%, and the same in the small group, the 12.5%. Is that right?
Correct.
And you heard some testimony today, I believe you testified to this from Mr. Pontiff, that those rates may be adjusted slightly. I believe the numbers that he gave were contingent on a 17% reduction on hospital budgets as ordered last year, 13.81% for the individual filing. Does that sound right?
That sounds right. Yeah.
In the small group, 14.29%. Is that right?
That sounds right.
And I think you've already said that the department's opinion on solvency remains unchanged, but that's going to be contingent on what L&E says. Is that right?
Yes. Yeah. As long as the actuaries agree where they land.
So barring some disagreement from L&E, the solvency opinion is unchanged, and the department's position is that there would not be a negative impact on solvency. Is that right?
Correct.
So still on 18, can you please read for me the last sentence of the third bulleted point on page 2?
Yes. The one that begins finally in 2022.
That's the beginning. Yeah, just the last sentence is all I need.
Nonetheless, adequacy of rates and contribution to surplus are necessary for all health insurers to maintain strength of capital that keeps pace with claims trends.
And that's standard language in your solvency opinions year to year, correct?
Yeah, and we had discussed this in previous rate filings, and it kind of echoes what Chris was saying, that the filing should stand on its own.
And this year, MVP sought a 1.5% contribution to reserves. Is it the department's opinion that that is adequate?
Yes, that all other things being equal, yeah, that seems like it would be adequate.
And that's for both filings, correct?
Correct.
Could you please turn for me to Exhibit 21? When you're there.
Exhibit 21.
And this is the L&E actuarial memorandum. Do you see that?
Yep.
And you looked at this briefly, is that correct?
Correct.
And you heard some testimony out today too, right?
I'm sorry, could you repeat that?
And you've heard some testimony today on it as well, right?
Yes.
Could you please turn to page 18? Well, starting on page 17, I'm looking at the section 12, changes in contribution to reserves. Do you see that?
Yeah.
And then continuing over to 18, there's a paragraph at the top that begins as a reasonableness check. Do you see that?
Yes.
And you heard some testimony on the reasonableness check today as well, right?
Yes.
And you're generally familiar that in the last few years, LNE has done a reasonableness check of MVP's CTR against nationwide health plan CTRs. Is that right?
Yes.
And would it be fair to say that MVP writes here, LNE writes here that MVP's filed CTR is somewhere in the 23rd percentile for all QHP carriers?
Yep, that's what it says.
And so that would be less than roughly 3/4 of all the QHP carriers, right?
Correct.
Could you please turn to the next page, page 19?
Okay.
And I see this page is headed recommendations. Do you see that?
Yes.
And you generally understand that this recommendations page is sort of a summary of the recommendations LNE is making to the board vis-a-vis MVP's rate requests?
Yes.
And to your knowledge, is LNE recommending any cut to MVP's CTR?
Not that I can see.
Okay, let's go back to page 18. I believe you touched on this briefly, but you heard Christopher Pontiff's testimony earlier today that continued negative profits are not sustainable. You recall that?
Yes.
I want to look at the paragraph on page 18, just under that historical RBC ratio table.
Okay.
Can you read, and this is a little tough, the second to last sentence that begins, LNE notes?
LNE notes that it is not sustainable to have long-term negative profits, and therefore a higher CTR could be justified.
So it looks like LNE agrees with what Mr. Pontiff said earlier today about long-term and negative profits. Is that right?
I have to object. I'm sorry. LNE can speak to whether it agrees or not with Mr. Pontiff.
Well, he certainly can speak to what's written on the page.
But you're asking him, does he agree with what LNE agrees with?
Okay, withdrawn.
Then go ahead.
Thank you. And does the department agree that long-term negative profits is not sustainable?
I would agree that long-term negative profits are not sustainable.
No further questions. Recall, I believe there's a contingent on LNE part here, so subject to recall after we hear from LNE.
Okay. Jesse, that means you'll need to stick around till the conclusion of LNE's testimony. Turn it over to the healthcare advocate now for any questions.
Sure, I just have a few questions, Mr. Lucier. We're going to stick on Exhibit 18. And so we've known each other for a few years now, and it feels a bit odd to call you Mr. Lucier. Would it be okay to call you Jesse and you can call me Eric?
That sounds fine.
All for reducing awkwardness. So in DFR's decision, it states that MVP's Vermont operations pose little risk to its solvency. Is that correct?
It says that operations, I believe it's pose less risk to its solvency compared to
New York.
Yeah.
Okay. And so it's been, you may have heard this, there was going back and forth a few times, and I think you're probably the best person to ask. Is solvency calculated at the entity level or looked at the entity level?
Generally speaking, solvency can be at the entity and or group level.
Okay. So if an organization operates in a bunch of multiple jurisdictions, what happens in one jurisdiction impacts the overall solvency of the organization, which has a role in terms of solvency opinion for a specific group of business. Wow, that was awkward.
All pieces of a business will, generally affect the solvency somehow.
Okay. And just to be clear, you DFR states that the proposed rate will not have a negative impact on MVP HP's solvency contingent on the GMCB's actuary not finding the rate inadequate, correct?
Correct, and that's also assuming that all of the factors, all else being equal with the rate filings, that something material doesn't change, if that makes sense. There's a possibility for losses because of increased costs in the future. Does that make sense?
It does.
Okay.
Thank you. So Jesse, I just want to probe a little bit. It's contingent on the GMCB's actuary not finding the rate inadequate, but I'm assuming, or would the actuary recommending that the rate be reduced change your opinion?
Not necessarily. I know there were a few differences between L&E and the company. And it sounds like for the most part, those were agreed on. So if L&E said, I think this component should go down by a percentage, and then MVP says, oh, we agree with that, then that wouldn't change our opinion.
And what happens if the two actuaries disagree? Right? There are things that the GMCB's actuary says should be reduced, and MVP says it shouldn't. Like, I don't know how to interpret the DFR's opinion in that scenario.
Yeah, I think we would defer to the board and the actuaries. I don't have the expertise to say which one would be right, nor do we have an actuary on staff at DFR.
Okay. All right, so I'm going to switch gears a little bit. This is, these may be a bit meta, these questions, so hopefully you can make sense of my babble, Jesse. So you say, DFR says that the proposed rate subject to the actuary's finding that it is not inadequate will not negatively impact MVP HP's solvency, right?
Right, that's what the letter says.
Yep. And so I'm assuming, correct, DFR doesn't know what will happen, correct?
What will happen with?
As in, like, you don't have some crystal ball for what will happen in the future.
No, the actuary estimates are their best estimates. So
then, go ahead.
No, I'm fine. Go ahead.
I guess then I'm just thinking about how to interpret that word will. I mean, is it maybe fair to say then that will is actually a may, or will contingent on future costs being as predicted by MVP's actuary?
Yeah, I think like I said before, it's all other things being equal. Assume